Good afternoon. I'm Ned Loughran, the Executive Director of the Council of Juvenile Correctional Administrators. CJCA represents the Youth Correctional Chief Officers in 50 states, the District of Columbia, Puerto Rico, and major metropolitan counties. Welcome to this afternoon's webinar on PTSD, screening, assessment, and treatment in juvenile justice facilities. This is the third in a series of 4 webinars on trauma-informed care that CJCA's Mental Health Work Group has been conducting. The previous webinars were Think Trauma, a training for staff in juvenile justice settings, Trauma Screens and Assessments, and the final webinar will be Trauma-Informed Care in Youth Correctional Facilities with Christopher Branson of the New York School of Medicine, presenting on August 17th. These webinars are archived. If you missed any of them, just go to the CJCA YouTube page and you can download them. You will receive a link to the PowerPoint slides of today's presentations after the webinar. We will have time after the presentation for questions from you. If you have a question for our presenter, please type it in at any time. I will read the questions in the order that we receive them. Please try to do this during the presentation and not wait to the end of the presentation. And now I'm very pleased to introduce Jennifer Jaworski. Jennifer is the Chief of Mental Health Services for the Illinois Department of Juvenile Justice, who will give some brief opening remarks about the work of the CJCA Mental Health Work Group, our today's sponsor, and also introduce today's presenter. Jennifer, it's all yours.
Thank you, Ned. Hello, everybody. As Ned said, I'm Jennifer Jaworski from the Illinois Department of Juvenile Justice. I am the chair of the Council of Juvenile Correctional Administrators Mental Health Work Group. Today's presentation was planned by the CJCA Mental Health Work Group. This group was formed over a year ago to help understand and improve mental health services in juvenile justice systems across the United States. CJCA realized that many of the mental health providers were struggling with the same issues: PREA, screening and assessment, trauma-informed care, substance abuse issues, evidence-based practice, and lawsuits over lack of adequate mental health services, just to name a few. By forming an administrative group of providers who oversee mental health services in juvenile justice facilities, we felt we could assist each other in addressing these issues. We thank CJCA and Ned Loughran for providing us the opportunity to meet monthly. We have spent much of the first year learning about the services each state provides in its facilities. We have come to realize not only our differences, but how much we share. Gaining knowledge of each state's juvenile justice operations has created a bond that allows many jurisdiction-to-jurisdiction conversations to occur. Members of our group support each other, and a wealth of information has been made available. The CJCA Mental Health Work Group also wanted to focus on a project to enhance services at our sites. We determined that trauma-informed care is an important issue and one we wanted more information on. Today's presentation is a result of those discussions. And as Ned described, we've already had 3 of our webinars. We have 1 more to come, and he listed those out, and those are on the CJCA site. Today's webinar is presented by Dr. Julian from the University of Connecticut Health Center. Julian Ford is a clinical psychologist and professor of psychiatry and law at the University of Connecticut School of Medicine. He is the director of the Center for Trauma Recovery and Juvenile Justice in the National Child Traumatic Stress Network, and has done clinical and research work in the juvenile justice systems for more than a decade after having worked with military veterans, adults, and youth with serious mental illness and addictions, community mental health clients in low-income urban communities, and adults with serious medical illnesses for more than 25 years. We are very lucky to have him presenting with us today. And we want to thank Dr. Ford for agreeing to share his knowledge on this subject with us. With that, I will hand the webinar over to Dr. Ford.
Great. Thank you very much, Dr. Jaworski, and thank you, Mr. Loughran, for the chance to meet with this wonderful group, and welcome all of you from CJCA Good afternoon and good morning to those of you on the West Coast. It's a real pleasure to be able to talk with you. I have to say, I'm going to take my screen off for just now. You've seen that I'm actually here in person, and I will stay on, but not on camera. I've learned a great deal. I'm a clinical psychologist, and I've learned a great deal in my work over the past 10 to 15 years with so many juvenile justice administrators, staff members, probation officers, community workers. It's been a real eye-opener for me to understand the crucial work that you and your programs do. And if we can provide you with some helpful information to support the work that you're doing and bring to you the trauma lens in a way that actually fits with the work that you do and fits with your perspectives and enables you to be as effective as possible, that's our goal. We don't want trauma-informed services to be a burden. We want them to be a true asset for all of you. And I know from the first two presentations, which were done by some of my colleagues from our center in the National Child Traumatic Stress Network, and the fourth one that you'll be hearing from Dr. Branson in the next presentation, we all share the common belief that work with youth and families who are experiencing the kinds of troubles that get kids into contact with the law and the courts, that's a vital part of making our country safer and making every community healthier and more productive. So I get to talk to you today about a specific part of that agenda, and that is screening, assessment, and treatment for post-traumatic stress disorder in juvenile justice programs. And I will acknowledge that I am, whoops, I will try to get there we go. I do have a commercial interest, and I'm not going to be pushing a product, but I am the co-owner of a company that was set up by the University of Connecticut to actually disseminate an intervention, some of which I will be telling you about, not to sell you, but to give you some examples of what good trauma, evidence-based trauma treatment can actually provide for you and your staff or the youth and families that you serve. So let's start off by just talking about the basics. Now, if you were able to attend the Think Trauma webinar, you may think this is all going to be very repetitive, but hopefully it'll build on what you've already learned. The first thing to think about in screening, assessing, or treating youth who have experienced traumatic stress or their families is what is it that we are really referring to when we're talking about psychological trauma. It can have many different meanings, and it's often used in a colloquial form to mean anything that's upsetting. And of course, for teenagers, for adolescents, their job description is to generally be in high stress mode. But what we're really talking about is stress to the nth degree. And we're talking about stress that is not just difficult or troubling or frustrating or leads you to question whether you can get up the next day, but stress that is actually a threat to your survival or to the survival of those who you care about, your family, other loved ones, your peers and friends. Survival threat without sufficient ability to protect and support yourself or those you care about. That creates a fundamental shift in how the brain processes. It does not damage the brain, but it shifts the brain into survival mode. And when that happens, people are often, adolescents as well as children and adults, are often able to cope enormously resiliently. But in many cases, no fault of theirs, for many different reasons, from genetics all the way through to community and larger environmental factors, when that kind of survival threat exceeds the person's ability to cope adaptively, then they have to not just simply cope but survive. And when they do that, then that becomes post-traumatic stress. And that's more than just a typical common stress reaction. So these are the kinds of traumatic stressors. We're all familiar with them. Hopefully most of us have not directly experienced them, but many of us have experienced one or more of these. And as we know, the youth involved in the juvenile justice systems, they are often exposed to multiple types of traumatic stressors in their lives, or have been. Those include stressors that that are impersonal but are still enormously life-changing and potentially threatening, like disasters or very, very serious illnesses or even deaths. Then there are interpersonal traumas that are the things that people do to one another, sometimes unintentional, sometimes intentional, but violence, as well as the opposite side of the coin, neglect, and perpetration of betrayal, of exploitation. Sex trafficking is a terrible example that leads, unfortunately, a small but growing number of youth to become involved with law enforcement and juvenile justice. So interpersonal trauma, which includes violence and victimization. And then there are traumas that are much broader scope that involve entire communities, nations, or even cultures. And those are the kinds of ethnic, ethnogenic, and even ethnic cleansing traumas that are experienced in so many countries in this world, and that many youth who come to our country from other countries may have experienced pervasive historical trauma. And many youth who are in our country now and have been and have families who've been in our country for generations have experienced historical trauma that goes back over many generations, where there is stigma, discrimination attached to racial and ethnic groups, to religious groups, to sexual identity groups. And when there are multiple types of trauma exposure, that's when it becomes really complex. And we have youth or adults who are polyvictims. They have experienced multiple types of traumatic exposure. And for them, very often, their self-protective systems and their survival systems in their brain and their body and in their behavior are so powerful that we have to really factor that into the work that we do with these youth, because they have to put a priority on survival, even though we are not threatening their survival, and we may be actually providing the best kind of support and opportunities to reset their lives and reprogram their environments. But nevertheless, they are going to be in survival mode. And that's really the essence of post-traumatic stress. So when youth or adults are trapped in violent relationships or communities, when they're subjected to prolonged captivity, when they are subject to ethnic cleansing or profound ethnoculturally based traumatic stigma and violence and discrimination, when they have experienced war or profound destruction of their communities, when they have experienced trafficking or multiple types of these profound interpersonal traumas, then what we need in order to work with these youth is we need to not be overwhelmed by the intensity of their experience and by the amount of information that we would have to factor in if we understood every single thing they went through. So a major part of trauma screening, assessment, and treatment is funneling this complexity down into a manageable set of procedures and practices that we can actually use to benefit youth who have experienced often profound and complex trauma. And so the core dilemmas really are these. And these are fundamental dilemmas for adolescents pretty much across the board, but they become amplified many, many times for those who have experienced traumatic stress or even polyvictimization. First of all, who can you trust? And how do you know that somebody is actually trustworthy if you've had your trust betrayed by people who you thought you could trust? How do you protect and stand up for yourself and those who you depend upon? How do you do that in a way where you're not victimized, where you're not vulnerable, where you're not exploited or taken advantage of, where you're not viewed as weak and therefore a potential victim? How do you do the right thing and live up to your values when others around you, including adults at times, as well as your peers, don't live up to those same values or do so in a way that is not predictable and dependable? And how do you do the right thing when you're feeling so threatened and stressed that really all you can think about is how to get through the next minute and how to try to defend yourself against the next potential assault or victimization? And finally, how can you afford, given all of these dilemmas, how can you afford as a teenager to stop and think before you react? And that's the fundamental dilemma that post-traumatic stress creates for all of us, as adults, or for the youth we work with, the fundamental dilemma is when you're in survival mode, there's not time to stop and think. You have to just act. And yet, the youth we work with cannot live in survival mode for their entire lives, or they will never be able to use the full capacities that they have, their intelligence, their support systems, their abilities. Instead, they'll just be constantly reacting as if it's a survival threat. So how do we help them to see that they're actually safe enough and that we and others in their life who they can identify can be trusted, will support them in protecting themselves and those who they care about, will support them in doing the right thing and not humiliate them when they make mistakes, even though we all feel very critical of ourselves and others when they don't live up to, or we don't live up to our values. And how can we be role models for doing the fundamental thing that has to be done in order to actually help a person to recover from trauma, and that is to stop and think long enough so that our reactions are a role model for how that can actually be highly effective and can get the youth we work with the success and achievement that they want. So with that in mind, then, we know that even though adolescents all over the world, in our country and worldwide, unfortunately 60 to 70%, if not more, experience traumatic stressors at some point in their childhood or adolescence. Another 15 to 30% are polyvictims. And then those who are involved in juvenile justice, we did a study in Connecticut with the partnering with our juvenile justice branch, the Court Support Services Division, and we were able to obtain trauma histories from almost 2,000 youth who were in detention. And what we found was that 40% or more, 41% to be exact, had histories of more than, or of at least or greater than 9 types of traumatic events. Not just traumatic events individually and not just a repetition of one violent episode or another, but 9 types of traumatic events, including exposure to sexual trauma, to physical violence, to physical neglect, to emotional abuse and emotional violence, to disasters, to life-threatening illnesses, to traumatic losses. And what you can see on the next slide is there's a group, that's the black line at the very top, and this group of youth, as many as 40% in this detention sample, had experienced, almost 90% of them had experienced traumatic losses. And 60 to 70% of them had experienced violence, including sexual violence. And this includes boys as well as girls, although tragically girls are much more likely to be subjected to sexual violence, but it is not just girls who are sexually victimized. So these are youth who have been through the ringer, and they are highly resilient, or they wouldn't even be in our programs. They are so resilient, but they are in survival mode. And so we don't have to teach them how to handle life better. We have to really help them learn how they can channel their intelligence, their resilience in ways that are not just reacting as if everything was a survival threat. Now you might wonder, is this also true for youth who are earlier on, not so deep into the juvenile justice system as those who might be in detention? So here's another group that we're working with in community-based programs that are both probation and diversion ordered. And these are youth who attend a program once or twice a week where they do groups that involve trauma recovery, but also substance abuse issues and anger management and restorative justice. And we did a survey similarly of these youth, and with a smaller group, but again, still a fairly large group, and about half of them were girls, so a much larger percentage than you will find in detention. Many were youth of color, and they ranged from as young as 7 years old all the way up to 18. 9% of them had experienced no traumatic events in their lives by their own report. And again, that may be an understatement. Some of these youth may not have really felt that they could reveal what they had been through, even on a very brief screen, as we will talk about. 11% had endorsed one type of trauma. Almost 40%, almost exactly the same percentage as youth in detention, were polyvictims with multiple types of trauma: traumatic loss, family violence, profound neglect. Even 1 in 5 had experienced sexual abuse, emotional violence, and community violence. So these youth who are much earlier in the juvenile justice system, at the early end where we can help them, prevent them from getting deeper into the JJ system, they also have a heavy trauma burden in their lives. And there you can see on the graph, that's the blue graph showing the kids who've had multiple types of trauma. But you notice that, again, there's a very large group of youth who have had someone who they depended upon for a primary relationship as a caregiver or as a close relative, family member, or friend. That's that spike in the green group of traumatic losses. So we always have to keep in mind that these are youth who have not only been dealing with violence in many cases and victimization, but also very often with tragic losses that have left them with profound sense of grief. So, now this is going to sound a little mental health-like to you, and those of you who are from the mental health profession, you may already be familiar with this, but I'm going to take you through a very quick tour of how PTSD is defined in the mental health community. For those of you who may not be familiar with this, probably many of you know of the Diagnostic and Statistical Manual of the American Psychiatric Association, this so-called DSM. And the reason I want to talk about this is not to go through a laundry list of symptoms that may either be familiar to you or may not even be that relevant, but to tell you how PTSD is now understood. It used to be understood primarily as a disorder of fear and anxiety, but now it is fundamentally understood as a series of problems or adaptations that are absolutely adaptive for survival, but are highly maladaptive for ordinary life because they involve being in chronic survival mode. And that's what I want to highlight for you. So the first part of PTSD is always exposure to some form of traumatic stressor, which is a life-threatening stressor or a stressor that fundamentally violates your body or your fundamental trust in other human beings. And this used to be a requirement for PTSD that there had to have been a sense of terrible fear, helplessness, or horror at the time or shortly after the traumatic event. And what we've learned is that very often adults as well as youth, when they experience a profoundly traumatic event, they are not aware of feeling terrified, horrified, or helpless. They often experience a sense of, I just have to deal with this. This is just part of my life. This is no big deal, or it is a very big deal, but I can't afford to get all emotional about this. And in some cases, they experience a very major shift that's called dissociation, where they literally tune out their emotions automatically, not intentionally, and they do that primarily so that they'll have the brain and bodily resources in order to cope with the survival threat. So dissociation, or shutting down and becoming numbed out, or literally going out of your body, that kind of a response actually is very adaptive for survival, but it can become a fundamental problem when it becomes a chronic way of coping with other stressors. So a traumatic event does not require that the individual is actively aware of being traumatized at the time. So many youth who are involved in juvenile justice experience multiple traumatic events where those have become so normative and so much a part of their lives that they literally are numbed out and do not experience them in the moment as traumatic. But you know that they are on survival mode. And that survival mode looks like this. First of all, it looks like reminders of any sort that are even remotely associated with traumatic events can trigger an intense sense of distress, of hypervigilance, which we'll come back to, and in some cases it can actually lead to the recollection of the event itself, maybe as a flashback or maybe just as a very troubling memory that you can't seem to get out of your mind. But in most cases, the way in which trauma is re-experienced is not a very specific memory. It's more of a sense of danger and threat triggered by even very remote associations. Triggers like anniversary dates, or birthdays, or even celebrations, or contact with family if you have been separated from your family because of child protection or because of being involved in detention or residential treatment or placements. Those kinds of re-experiencing triggers are not because of a threat. They're because the youth at that moment is remembering how traumatic events and the violence and victimization that they or others they care about, how those traumatic events have deprived them of the ordinary kinds of pleasures and security and support that we all count on with birthdays, with holidays, with anniversaries, with family get-togethers. And again, you don't have to have a perfect family in order to count on that support. You don't have to have perfect friends to count on that support, but if the contact that you have with family or friends is a reminder of horrible violence or terrible losses, then even that kind of a positive experience can trigger a sense of survival threat. And that's something we have to then take into account. We can't prevent kids from having contact with their families. In fact, we want to encourage that when it is actually supportive and done under the right conditions. But we do need to be aware that that might trigger stress reactions that may lead to difficulties with those family visits or with those family reunifications. And that's what we need to prepare the youth for, as well as the family, rather than just sending them into that kind of situation as if there's nothing that's going to happen because everything's going so well. So we need to be thoughtful and savvy about the fact that there are many reminders for youth who've experienced traumatic stressors that bring back the sense of vulnerability and survival threat, even though they may not bring back very specific and overwhelming actual memories. But then survival mode isn't just troubling memories or reminders. It's also the attempt to avoid any kind of situation that could potentially be reminiscent of traumatic events, and that can involve avoiding danger, but it also can involve avoiding closeness with others, actually being involved in relationships. It can involve avoiding talking about what's really going on with you at this moment. So it can lead to the kind of callous, unemotional, non-compliant, in quotation marks, behavior that is a major issue for many youth and for many of us who work with youth and juvenile justice. In many cases, they're not trying to be non-compliant, and they're not actually callous and unemotional. They're just trying to shut down any kind of reminders or any kind of emotional reaction on their part that might make them vulnerable. And that's very different than not having a conscience or not being willing to actually work with the people who are trying to help you. It's more like a test. Are these people really trying to help? And I've got to make sure that I screen very carefully. So they're doing the screening of us in many cases, just as much as we may be trying to screen for some of their trauma exposures and trauma history as well. And then there's a whole new set of symptoms in PTSD that didn't even used to be included. And just to cut to the chase, fundamentally, these are symptoms where the young man, the young woman, the boy or the girl, they are fundamentally experiencing the world, relationships, and even themselves as sources of threat. And so they have exaggerated negative expectations that may be accurate about some people some of the time and some of what they've experienced, but when they generalize it beyond those situations, and now they're trying to live their lives as if no one can be trusted, as if there's no future to look forward to, as if they are fundamentally damaged, that's when we have a youth who's basically trying just, again, to survive. And they may, as a result, have an exaggerated sense of blame, and it may be self-blame. It often is, even though it may be disguised as blame of others. And it may be a combination of the two. And they fundamentally are not just anxious or scared. They're angry, they're frustrated, they're often plagued by a sense of guilt because of things that they think they should have done and they either couldn't do or didn't do. Sometimes shame because they have violated their own values, even though they may not be very willing at all to disclose that. Those kinds of pervasive emotional states and fundamental shifts in beliefs lead a person to essentially expect that their survival is going to be constantly in jeopardy. So now we have a self-fulfilling prophecy. And the final piece to that puzzle is the hypervigilance and hyperarousal. So if you expect that you really can't trust much of anything or anyone, including yourself, and the danger is around every corner, and that you can't afford to be blindsided, then you're going to be hypervigilant, and you're going to be ready to react aggressively, whether it's verbally or physically. And you're going to potentially view the world as a place where you might as well just go ahead and do something wild because it's going to happen anyway, and that's where some of the reckless behavior comes in. Or in some cases it comes back to, well, if I can't control anything else, I'll harm myself. And sometimes the pain that comes from self-harm, from self-injury, is actually easier to cope with for trauma survivors than any other kind of pain. It's actually less painful than the pain that's inflicted by others. So now we have youth who are expecting the worst, they're on edge, they're on guard, and we have to then make sure that we factor all of that into our services. That's a lot to do. Well, the first thing we need to then think about is, well, what do we need to know? Well, I would suggest to you that while there are some excellent screeners, and the previous webinar talked about this in some depth, I'm just going to mention a couple of screening instruments that are potentially very useful. But again, in juvenile justice settings, you can almost be assured that trauma history is very likely to be a part of most of the youth's lives that you're working with. And so it's not a question so much of if, but of what, and how they've had to adapt in order to survive. So the structured trauma-related experiences and symptoms screener, the STRESS, is a very good example. It asks about 20 questions related to different forms of adversity and trauma exposure, including bullying, including domestic violence, community violence, sexual abuse, sexual assault, as well as emotional abuse, as well as difficulties in families that are breaking up because of family members having significant mental health or substance abuse issues. It also asks the questions that we need to understand in order to be able to identify PTSD. But again, for many of us, it's not so much a question of whether we're going to diagnose PTSD, although we may want to refer in many cases for that kind of a diagnostic assessment, but it's really more a question of which of these kinds of survival adaptations are the most troubling and the ones that need to be most focused on in order to help this youth get out of survival mode. The PTSD checklist for DSM-5 has a life event screen that's very similar. If you're working with youth who have ever been involved, or young adults who have been involved with the military, there is a deployment risk and resilience inventory that's specifically for military personnel. Probably not something that you'll be using with your juvenile justice clients or supervisees all that often, but it's very useful to have that in your toolkit when you're working with veterans, because it is a very thorough survey of the kinds of stressors and adversities that military personnel experience when they're deployed. The Adverse Childhood Experiences Scale is a very nice brief 10-item measure that basically asks about things like sexual abuse, physical abuse, parents who are impaired by serious mental health or substance use issues, domestic violence. A longer screener that a group of us have developed is called the Traumatic Event Screening Instrument, and that's something that's probably not going to be so useful unless it is used in the context of a trauma-informed system, and that's how we did the screening for the studies that I showed you the results of a little bit earlier. But this is a screen that asks about multiple types of traumatic events, as does the Childhood Trauma Questionnaire. And it's probably most useful if it then leads to a potential referral rather than attempting to use it as a primary screener. When we're talking about the screening and assessment, the other thing in screening that I want to mention to you is just there's also a very nice 4-item screen called the Primary Care PTSD screen. That's the fourth one down, or excuse me, the third one down on this list under in the first group. And that inquires about 4 of the PTSD symptoms, and it's actually a very nice brief screener to identify youth or adults who may be experiencing a variety of PTSD symptoms, because it hones in on some of the core PTSD symptoms. there's another measure called the Symptoms of Trauma Scale, which is very useful for clinicians who are doing more referral and assessment work once a youth has been identified who may have significant traumatic stress issues. And that's called the Symptoms of Trauma Scale, Traumatic Stress Scale, the SOTS. And then there's the gold standard for assessment for diagnostic purposes, which also can be very useful for treatment planning, the clinician-administered PTSD scale for children and adolescents. And that's a very thorough survey of the primary PTSD symptoms that I've just reviewed for you. That should be done by a clinician who has training and who's very used to taking not only self-report, but also observing very carefully, because one of the things that we all need to be very cautious about in screening or assessment of PTSD with adolescents is their tendency to be highly avoidant. And in so doing, they will often say that they actually are not avoiding. So one form of avoidance, paradoxical as it may sound, is to avoid even disclosing how much you're avoiding. And in many cases, youth aren't aware of avoidance. They're doing it so second nature and just by instinct that they don't even recognize their own avoidance strategies. And that's where we potentially can help them, not by outing them and making them more concerned about having additional symptoms, but by helping them see that when they do avoid certain reminders, it may be an adaptive response, but it also may be something that just intensifies their sense of being in survival threat. Coping that is avoidant, that increases a sense of personal control because you're selecting where, with whom, and what you do, that's going to reduce PTSD. But coping that increases a sense of vulnerability, vigilance, and distrust, that's unfortunately going to increase PTSD. And that's the kind of assessment question that has to be very carefully teased out by listening to how youth describe how they handle situations, and not just simply asking them a question, do you avoid reminders of past traumatic events? You'll get a no to that question almost without exception for most youth. But when you probe a little deeper, and not going into a kind of a depth psychoanalytic probing, but just learning about their lives, you often learn that yes, they do in fact avoid. And it's both adaptive because it reduces some of their sense of threat, but it's also maladaptive because it prolongs their chronic sense that they're never safe. So once we've identified a youth who has some significant PTSD issues, and again, that doesn't have to be a full diagnosis of PTSD for the symptoms to be significantly impairing. That's really an important point to keep in mind. The treatment options. Well, first of all, there are psychotropic medications that have been useful in treatment of PTSD with adults, but there is no drug, no prescribed medication that is FDA approved for children or adolescents with PTSD. And in fact, there have been at least a couple of randomized clinical trial studies that have shown that some of the medications, for example, like one of the selective serotonergic reuptake inhibitors, SSRIs, some of the new generation antidepressant medications, which can be very helpful in adult PTSD treatment, were not actually helpful with kids. They're probably not harmful. There is some concern about some of those medications that are activating, actually increasing suicidal risk. That's something to be cautious about. But the most fundamental concern is that these are not medications. There are no medications, anti-anxiety medications, antidepressant medications, let alone antipsychotic medications or anti-epileptic seizure control medications. None of those have been demonstrated to be effective with adolescents with PTSD. They may help in very limited for very specific symptoms, but they are not a frontline treatment and they should be used with great caution. So psychotherapy really is the primary treatment modality. And there are a number of excellent evidence-informed child and adolescent PTSD psychotherapies. Some work with younger children, and some work with the group that we're talking about, adolescents primarily, or children and adolescents. And these interventions, which you can see a list of them right here, from cognitive processing therapy, cognitive behavioral intervention for trauma in the schools, eye movement desensitization and reprocessing, which you may have heard of, EMDR. Another approach that is more well known in Europe, KID, narrative exposure therapy, prolonged exposure therapy, trauma and grief components therapy for adolescents, a lesser known but an approach that deserves some close attention, as we'll see, and trauma affect regulation, guide for education and therapy and intervention that I've helped to develop, as well as a very widely disseminated intervention, trauma-focused cognitive behavior therapy, TFCBT. So these are all interventions that have potential utility. Let's talk about what they do rather than talking about any one of them. So as group therapies, and the two that have been validated for adolescents, and in particular adolescents involved in juvenile justice as group therapies, target and trauma and grief components therapy, TGCT, they really are a way of helping adolescents to understand the survival reactions that they are experiencing, how those make sense so that they don't feel a sense of stigma or as if they're just a trauma victim and they can never get over it, how they can actually take charge of their survival and stress reactions in a way that can help them to be more effective, how they can deal with memories of traumatic events if those are troubling them, but most importantly, how they can actually take stress reactions now and stop and think before they react, which is, of course, the crucial goal that we have for any adolescent. Group therapies tend to be pretty efficient because you can work with several kids at once. If they promote pro-social interaction, if they degenerate into just a kind of a group, I don't even know how to say it, a group kind of a festival of complaints and random talk, that's not helpful. But it's very possible to use these interventions in a way that actually engages youth pro-socially. They can be open enrollment if you have kids coming through a program or through a probation office or a diversion program. They can be done, the target group can be done on an open enrollment basis. It can also be done on a closed enrollment basis where kids come in and they are involved in the group for a defined period of time. We generally recommend that groups such as these are done separately for younger, that is pre-adolescent or early adolescents and younger versus older adolescents, and separately by gender whenever possible, because there are a lot of male-female issues that complicate the discussions and can be very helpful but tend to generally lead to a lot of distractions, and probably that's true for most interventions. These are also interventions that can be done on an individual therapy basis. That's less efficient, but it promotes a one-to-one mentoring kind of relationship, and it can reduce some of the connections with other peers that who are quote-unquote modeling deviant peer interaction kinds of behaviors. It can also be done, one of them, Target, has been done as a family and milieu therapy, and that's where it can be done with parents and kids together, or it can be done on an entire detention unit or in an entire residential treatment program. And that can also be a way of involving staff at all levels in the work, which is really crucial because treatment is only a small portion of youth lives, as we all know. So there are a number of barriers to actually implementing these treatments effectively in the juvenile justice system or by referral from the juvenile justice system. Clearly there are multiple risks and needs that these youth have, and there are multiple models and there are many different approaches, so it can be kind of difficult to decide which model should we use. It's often best to think of models that work well together. So one example, just one of many, is that we've done Target, which I will tell you more about, in combination with multi-systemic therapy and also multi-dimensional family therapy, two evidence-based interventions for youth with substance use issues, and also sometimes there are modifications of MST for youth who have sexual behavior difficulties as well. When interventions are willing to work together and do so in a complementary fashion, that maximizes your gains. What you don't want, of course, is having fragmented, compartmentalized interventions where a youth does a trauma intervention for a period of time and then that stops, and then they do a behavior management or a parent management intervention like multi-systemic therapy, and the two are disconnected as if they're not actually part of the same overall program. So we look for interventions that are able and willing to work together and that are complementary. It's also really important to engage youth in a way that actually addresses their goals. So we know that what I mentioned earlier, Patricia Carrig has done some wonderful work at the University of Utah on what she calls acquired callous and unemotional traits. And that's the youth who is emotionally numbed, not psychopathic, but is numbed out by having to cope with multiple recurrent traumatic stress survival threats. And for those youth especially, it's really important to engage them rather than just to insist that they comply with treatment, because then you'll get them voting with their feet or voting with their lack of attention. It's also crucial to provide support and stability if the intervention is going to involve actual discussion or processing of trauma memories. So some of these interventions help youth to talk through events that have happened that they may be trying to avoid and that may actually be triggering all kinds of hypervigilance, because the more you try to avoid something, the more that you find yourself thinking about it. In that case, when trauma memories are frankly talked about, this needs to be done in a very careful step-by-step process, and there needs to be involvement of adults and other members of the youth community who can support the youth, not necessarily during the discussion of their trauma memories, but as they are kind of processing what they've disclosed. And in some cases, it's really important for youth to share what they have been through with very specific members of their family, such as parents or primary caregivers. And that can only be done if those primary caregivers or parents are actually available and if it's logistically possible for them to be a part of the treatment. It's also true that if you just do therapy once a week or a group for once or twice a week, that's not going to generalize very effectively to the rest of these youth lives. And if they're involved in programs in the community or in residential settings or detention settings, it's really crucial to reinforce what they're learning in treatment in those settings. Otherwise, treatment is one thing and life is something else. And when that happens, that split leads youth to just discount what they learn in the treatment process, and then we've lost an opportunity. So here's an example. Again, this is an intervention that derives from many of the other interventions that I've listed. It has some unique elements that I want to show to you that are just examples of ways in which we can engage youth, engage parents as well, make this a collaboration where staff, probation officers, detention staff, diversion staff, case managers, community workers, as well as judges and administrators are all on the same page when they're talking about how trauma has affected these youth and what they can do about it that's a part of their responsible rehabilitation as well as about their personal recovery. So what we teach in Target is very straightforward and simple, and yet it's very complex. We basically teach kids and adults, and this is just as applicable to all of us as administrators, as staff, as clinicians, as judges, as it is to the youth. And in fact, in some cases, we're the ones who need to be most mindful about this, and then if we understand it, we can teach it. So the thing that people need to know about traumatic stress is it's just a variation of the normal stress response, and that involves three parts of the brain. An alarm system that tells us when we're not safe or when we need to wake up, a filing center that helps us pull out memories that allow us to know what we need to know about this situation in order to handle it from our past experience, and then a thinking center that basically comes up with a plan of action. Now, when stress is being handled very effectively by someone of any age, what happens is as the alarm goes off, information from past experience is accessed and a plan is formulated. The individual is able to stop, even if only for just a moment, recall what they know, think about a plan that makes sense and that fits with who they are as a person and what they value, as well as what the circumstances are. And when that plan is formulated, that's what turns down the stress alarm in the brain. And literally you see this in studies that do brain imaging with kids as well as adults. Those who have PTSD have alarms in their brain that they just do not know how to turn down. And that's what we fundamentally need to show them how to do. So how do you help somebody who is too stressed to remember to stop and think, because in their workplace, that's us, or their life, that's the youth we're working with, or us as well, their alarm in their brain has gotten stuck on high alert. And that's when post-traumatic stress becomes a problem, not just a healthy adaptation to survive difficult or even traumatic circumstances. That's when our brain's alarm can actually hijack our body and our lives. And this is what it looks like. So now we have an alarm in the brain that is on such high alert that literally the memories and the information that it pulled out of the brain's filing center are all about disasters, traumas, emergencies, danger, threats, distrust, betrayal, exploitation. And of course, with that kind of information, the thinking center, if the hard drive isn't just completely blown out, and I mean the brain's hard drive in this case, it's literally going to be overwhelmed, and any one of us would be experiencing a syndrome that we all know, TMI, too much information. And as a result, the alarm never gets turned down. And that's what this looks like. In this case, Snoopy's alarm, if you'll forgive me, and with Charles Schultz's permission, Snoopy's alarm is turned on by a non-traumatic stressor where there may be some historical trauma in his canine experience with felines, and he has a very powerful alarm reaction, and as a result, he's pretty discombobulated. Well, that's kind of cute and funny to look at, but if that's an adolescent who's experiencing multiple triggers throughout every day and not just once in a while, and they're having that same kind of stress reaction recurrently, we have to help them figure out how to handle those stress reactions. So we have to be able to show them that it's possible to reset and turn down the alarm in their own brain, and that this does not involve medication, it does not involve psychosurgery, it involves harnessing the power of the brain's filing center and thinking center by being able to remember their core values, who they are as a person, and who and what gives their life joy and purpose. And that might seem like kind of happy mental health talk, but it's fundamentally how we all reorient. And what we do in Target is we teach, it's as simple as 1, 2, 3, SOS. Stop, get oriented, and then check yourself before you act. And the way that we teach kids and adults, staff, clinicians, judges, administrators, all of us, we can all use this because we all have stress even if we don't have trauma. The first step is simply stopping and sweeping your mind clear. And you see how kids will do that when they stop and freeze for just a moment. But then so often if they're trauma survivors or if they're experiencing post-traumatic stress, they don't catch that moment and instead they react. And the essence of being able to recover from traumatic stress, as well as to be a responsible citizen and a responsible member of the community, is to be able to catch that moment where you stop and then reorient. And what we teach is it's as simple as identifying one thought that you choose based on what you value and who you are as a person. Now that's something that teenagers often will laugh off initially, but when that's brought back to their attention, not as something they have to do, but as something that they can do, something that they have the ability to do, but only if they choose to catch that alarm reaction, and if they practice doing so when they're not under high stress circumstances. It's amazing how teenagers can become very, very engaged in the process of being able to orient themselves so that they don't just react without thinking, and so that they don't make the same mistakes that they see their friends, their peers, even the adults in their lives make when they stop and then don't think and ready, fire, aim. And then the self-check is just a simple way of being able to capture how much stress am I feeling right at this moment, because so often for kids and adults who are experiencing post-traumatic stress, their first sense is this is a 10 on the stress scale, this is the worst ever. But if they take even a second or 2 seconds to just check in, most often what they're experiencing is not a 10, it's an 8, a 6, a 5. But their alarm is going off as if it was a life-threatening 10-level stressor. And the very act of just recalibrating by checking your stress level actually enables kids to begin to turn down their alarm. And then if they also check in on their level of personal control, we teach that this is not about controlling the environment or controlling other people. This is about the kind of control that you have when you're able to think clearly at this moment. And that kind of personal control is power that makes athletes famous and successful, that makes celebrities popular, makes musicians highly popular and highly artistically successful. It's the key to success in every area of life. It's not just about trauma recovery. So personal control then becomes something that kids can actually pay attention to. And using this simple three-step process, which is pretty much the essence of every one of the treatments that I've shown you earlier, they all teach in different ways how kids can shift from reacting to focusing. This is just a very specific template for doing that might be useful. And these are the kinds of rating scales that we show kids. And then if we're able to work with youth over a longer period of time, maybe in a group or an individual therapy or maybe in family therapy, we teach them that after you've focused, you can use these same skills to basically hone in on what is it that's triggering you, rather than reacting to everything as if everything's a trigger. And then identifying the emotions, the thoughts, and the goals that are coming from their alarm, but also the emotions and the thoughts and the goals that represent what they fundamentally value. And when they focus on that dialectic, that kind of back and forth between my alarm is telling me to feel scared and angry, but I know that this is somebody who I actually care about, and I feel a sense of closeness to this person, except right now I'm really angry at them. At that moment then, I can think about ways in which I'm going to get them back or make them pay, but I could also think about ways in which I actually want to repair whatever harm has been done to this relationship, and how I can participate in that as well as engaging them. And then I have a different kind of goal. I might have a goal that's to get revenge, but I have a counterpoint goal that's to work this out. And that's where kids start to actually realize that when they come up with the goals that are the pro-social goals, that are the restorative justice kinds of goals, when they come up with them not because they're told that they have to, but because they choose those goals as something to focus on in order to have control over their own inner alarm system. That might seem like a stretch, but in 4 to 10 sessions, we've seen kids adopt that perspective and begin to practice it and actually shift so that they're no longer just reacting without thinking. They actually realize they have the capacity to focus in on what is actually their main side of their life, their core values, beliefs, and loyalties, the attachments that give them a sense of security and love, the kind of peace and calm confidence that every teenager wants and most struggle with and that we all have to work hard at. And they realize that they actually can shift out of alarm mode into being able to actually think clearly about what they truly view as important in their lives. And when we as adults do the same thing, when we use the same approach in how we interact with them, when we don't just teach it but we role model it, which is what effective people in the juvenile justice system are doing every day. But most of us don't realize that we're actually role modeling this way of constructive, effective thinking, emotion processing, and literally handling stress and stress management. So as we do that, we are the role models for youth, and they begin to see that they could do it too. What I've just shown you is the kind of didactic and therapeutic information that allows youth to know what is it that a highly successful and effective person, somebody who they trust and feel they can be safe with, even though they're very reluctant to do that, that person doesn't have magic. That person simply knows how to do exactly these steps. And that person knows how to go from focusing all the way down, or all the way up, I should say, to being able to make a contribution, to being the kind of person who makes a difference in other person's lives, who does protect the people they care about, but also does it in a way that does no harm, and that literally is win-win for everyone, whenever that's humanly possible. And that's making a contribution. And that's ultimately what trauma therapy, trauma screening, and trauma assessment are all about. They're a way that we can introduce youths, and that we can also introduce ourselves to this opportunity that they have and that we have, to literally make a contribution by shifting from being in alarm mode, which is the hallmark of post-traumatic survival coping, to be able to take that alarm reaction and use our mindful, resilient brains to actually come up with what we value and what the choices are that will make this a better world. Now that's asking a lot from kids, but they are so driven to be ethical. They are so driven to focus in on what's right and what's wrong that this is actually a natural sell for them in many cases. And ultimately, to wrap this up, we all need to just simply take into account that even though it's usually treated as, oh no, I don't want to think about this, vicarious trauma. Well, it's true that working with youth and families who themselves have experienced often profound, often complex, multiple types of traumatic experiences, losses, and victimization, it's impossible not to be affected. Most of us, if not all of us, have found ways to manage our own reactions, to take care of our own emotional health, and this is not to suggest that any of us need therapy. It's simply to be a reminder that we all need to do exactly what we're teaching, to put on the oxygen mask and use those freedom steps or that SOS ourselves, as well as teaching it to the youth we work with. Because if we don't use it, they can tell. And they know if we're just talking the talk as opposed to when we're walking the walk. So if you're wondering, well, is this intervention and these types of interventions, is there any evidence? Well, in fact, we've actually done a couple of randomized controlled trials, one with girls who were involved in delinquency and another one with incarcerated women, many of whom were very young adults and just barely out of the juvenile justice system. We've also done field studies that have actually tested this intervention in juvenile detention, in secure juvenile justice facilities for kids who also have serious mental health and substance abuse problems. And we're also doing a study now where we are actually looking at how this kind of screening to identify kids who are polyvictims can actually enhance probation and other kinds of juvenile justice recommendation, planning, and programming. And just to give you a quick example, when this intervention was done as a group, the target intervention, with about 400 kids in detention, most of whom were male, what we found was that for every group session that they received in the first week of their usually approximately 2-week stay in detention, there were 54% fewer dangerous incidents. There were 72 minutes less time that each one of these individual youth spent in seclusion or room time. And recidivism also decreased during the period of time when this intervention was being used. So it potentially has a very powerful effect. With another group of kids who were involved in an inpatient mental health secure facility after having been remanded there by the court, for a smaller group of them, but still a substantial group, when this intervention was done on the entire unit, so as a group intervention, but also for everyone on the program. What was found was that in the 6 months before and the 12 months after this intervention was implemented, on units that did not implement the intervention, there was a 3 to 4 times increase in the level of dangerous incidents, seclusion, and physical restraints. Unfortunately, they were working with a very challenging group of youth, and they were being asked to take in kids who had significantly higher levels of severity of both mental health and also legal issues. On the target units, by contrast, there was a 50 to 75% decrease in incidents, seclusion, physical restraints, and those youth also reported improvements in depression as well as PTSD symptoms, and an increased sense of hope and actually willingness to engage with the staff in their programs, not just the trauma part, but all the programs. And that's what it looked like in terms of seclusion. Tragically, on the usual care units, there was a great increase during that period of time in the use of seclusion, whereas on the units that were using this intervention, there was a decrease that actually stayed fairly steady over time. Here are some resources that you might want to check out: the International Society for Traumatic Stress Studies, the International Society for the Study of Trauma and Dissociation. For youth, the National Child Traumatic Stress Network, NCTSN, is an excellent set of programs nationwide. The American Psychological Association has a trauma division. For those of you who are interested in screening for ACEs, Adverse Childhood Experiences, there is a website for that. And those of you who are interested in the intervention model, there's the website for advanced trauma. And you also might find a couple of fact sheets that my colleagues and I have done for the National Child Traumatic Stress Center Network and our Center for Trauma Recovery and Juvenile Justice. We have fact sheets that are freely available on the web on assessing psychological trauma and post-traumatic stress, as well as on evidence-informed treatments for kids in the juvenile justice system who have post-traumatic stress problems.
We have had Dr. Olafson also present at our last meeting. So all three authors at the top there, we have been lucky enough to have present in our CJCA work group.
There you go. Well, and on that note, I will turn it back over to Dr. Jaworski for comments and questions. Thank you very much.
Thank you so much. Brendan, you are going to handle the questions, right?
Actually, Ned is going to handle the questions.
Okay.
Brendan is in another webinar, a distance learning call for the performance-based standards group. But one of the last comments that came in, I think, sums up what we feel here and what I think many of you feel who have been listening. It said, what a terrific update on PTSD. Thank you very much. Dr. Ford, thanks so much for that. It was a tremendous primer for many of us and a reinforcement for many others. So a couple of questions that have been coming in. I think this person meant, what about the Massachusetts, they said youth survey. I think they meant the Massachusetts Youth Screening Assessment. This was a question coming from Alabama. That's the screening assessment that Dr. Tom Grisso and Dr. Barnum created, which I know you're very familiar with. I guess the question is, does it screen for trauma? I know it screens for suicide ideation. I'm not sure myself whether or not it screens for trauma.
Well, that's a great question. Thank you, Ned, and thanks to the audience member who raised that. I should have included the MAISY too. The reason I didn't is because it does have a subscale called the Traumatic Experiences Subscale. That is being revised now by Dr. Grisso and his colleagues, as well as with Dr. Carrig from our center, because it actually has some real utility. And another one of our colleagues, Dr. Keith Cruz from Fordham, has just been doing some research showing that screening scale, if you just use the actual events, and it asked about physical abuse and violence, if you just use the traumatic experience items from that subscale of the MAISY, that actually is a very useful screen. We didn't realize that until we've just been doing some analyses with some of the data that I've just mentioned to you from Connecticut. The traumatic experiences subscale overall is not any more accurate in identifying youth who have significant traumatic stress issues than the depression and anxiety subscale or the anger and irritability subscale. And yes, the suicidal ideation subscale is also a very important one that is related to traumatic exposure, although it doesn't identify kids who have PTSD issues, but it identifies kids who have very serious additional complications of suicidal ideation. So the MAISY 2, because it's used in almost every juvenile justice system in this country, it certainly is an excellent first line for screening. But again, I would be cautious. The symptom questions, and there are just a couple of them on the MAISY 2 trauma experiences scale, those have not proved quite as useful And so the overall scale score and using that for screening is probably not going to be as useful as just simply identifying youth who endorse the traumatic events on the MAISY traumatic exposure or traumatic experiences subscale. So that's what I would recommend, and then that can lead on to some of the slightly longer screeners like the stress. So thank you.
And there was a question on another assessment instrument, screen or assessment instrument. It's are you familiar with the UCLA PTSD Reaction Index of children and adolescents, and do you think that it is appropriate for use in a juvenile probation department at the intake stage?
Excellent question. It's an outstanding instrument. The UCLA group are leaders in the National Child Traumatic Stress Network, and the measure is a very good one. It is a measure that can be used early on in probation or in diversion programs, but it's very similar. It's actually almost identical in many respects to the stress. The only issue about it, and again, it's just one that has to be considered, is that it's commercially available, so there is some cost involved in getting them in the measure. However, that said, it's equally as comprehensive as the stress in terms of trauma history and also post-traumatic stress symptoms. It's been well validated, so it's an excellent measure. And I only referred to the stress because that is not a commercial product. Both of these should be used early on in intake, for example, probation intake, only if the probation officer have had training in how to interpret the responses, because that's a lot of information. You're going to learn about a lot of different types of potential trauma exposure, a wide variety of symptoms as we've discussed, and so it's really important that the probation officers have the support and the background to be able to actually use that information. In our juvenile justice system in Connecticut, the probation has decided that it's better to use a briefer screener initially, so that probation officers are not being asked to interpret a wide range of potential trauma exposures and traumatic stress symptoms. But again, both approaches are perfectly reasonable. It's a matter of how many resources there are and how much support can be provided, because while these are not measures, the UCLA Reaction Index and the stress, they don't diagnose PTSD, but they give a very thorough survey of trauma exposure and post-traumatic stress symptoms, and that's a lot of information to incorporate into an intake assessment.
Another question is about the cross-cultural nature of any of the surveys. Are there some that stand out in terms of their cross-cultural in their administration?
Both the UCLA Reaction Index and the stress have been validated with samples of youth and children who come from a variety of different ethnocultural backgrounds. There is for a broader network, if, for example, you're in a community where there are many, many children or youth who come from, whose families have recently immigrated, that is a whole different ball of wax. And there's a center in the National Child Traumatic Stress Network in Boston, Center for, I can't remember the exact name, but if you just Google National Child Traumatic Stress Network and the Immigrant and Refugee Trauma Center, I believe is the name. They have some wonderful resources that I'm not as familiar with, but if that's a population, or if that is part of the population that a community is working with, it's really good to get access to measures that are specifically geared to the experience that people coming from other countries and other cultures may have. But beyond that, the basic screening measures that I've talked to you about have been well validated within the cultural diversity that we have primarily amongst native members of, or native residents of the United States.
Good. Thank you. And this is a question from someone who works in a juvenile facility that they would like to develop an evidence-based they'd like to develop an evidence-based practice program and an informed trauma control for adolescents. They're hoping for any suggestions from you. So they want to develop an evidence-based practice program and an informed trauma control for adolescents?
Wow, that's the $60,000 question, and I would say that probably the best thing that they could do would be to check out the fact sheet that Dr. Carrig and Dr. Olesen and I did for a briefer and a little bit more concise listing of some of the interventions that have been specifically tested with juvenile justice facilities, and then look at those and consider trauma and grief components therapy is one, target is another, cognitive processing therapy has been used in one study, prolonged exposure is another. It really depends upon what your unit's primary goals, needs, and resources are. But those are at least some good starting points to be thinking about, and then talk with the model developers, because most of us are very, very open in talking about what our models can and can't do. Oh, and I certainly shouldn't leave out trauma-focused cognitive behavior therapy, because that is widely used. It's more of an individually focused rather than a group-focused therapy, but that could be a really important component in providing treatment resources, maybe not so much on the unit, but associated with referrals from the unit. So I would say start with that fact sheet and look at, there's a number of other resources in the Child Traumatic Stress Network. We're just completing a very nice brief guide that's going to be called Essential Elements for Trauma-Informed Juvenile Justice Systems, and that'll be up on the web probably within the next month or so. And also consider that a great starting point would be going back to the first webinar and Dr. Merrow's presentation on Think Trauma. That's a tremendous brief training module and toolkit that can help staff and administrators and clinicians at all levels to begin to develop a kind of a trauma lens, and from that you can often build highly effective programming that might involve interventions that are not specific to traumatic stress, that have more to do with the specific issues, whether it has to do with emotion regulation or responsible behavior. There are a variety of interventions that can be woven into a trauma-informed facility, and Think Trauma is an excellent place to start with that.
This is an interesting question about a person who sees the value of using the screening tools for assessing trauma, but then how do you complement that with an interview or a conversation with the person about their trauma history?
Well, that is an excellent point, and that is actually the ideal practice. So I'm glad that the audience member mentioned that. It's great to know what has happened in kids' lives so that we are at least aware of what's maybe some of the triggers for them and some of their stress reactions that may have contributed to some of their legal problems or behavioral problems. But ultimately, the greatest value of the screening is if you can sit down as a detention staff member, as a probation officer, and weave into the discussion that you would have anyway. Not have a trauma discussion, but have a regular services supervision discussion, and weave into that some of the ways in which you've seen this boy or girl react that are consistent with some of the symptoms they've described. And rather than saying, well, that means you have a PTSD symptom, of course, that's not going to be terribly helpful. But instead to say, you know, we've all been learning about the way in which that kind of a reaction might be something that's happening because your stress alarm is triggered, and you're kind of shifting into a survival mode. And one of the things that I've seen you be able to do is sometimes I've seen you catch yourself when you're having that kind of reaction. Can you think of any times where you've been able to catch a stress reaction and you've actually been able to stop and think your way through it? And then, of course, if there are examples that the staff member already has, just to show the youth that they've actually been paying attention and are strength-based in their focus, that can be a really nice way of engaging the youth. Rather than saying, you know, let's talk about your trauma, it's really a way of saying, let's talk about how you're able to actually handle the kinds of stress reactions that we know have to do with this alarm going off. And you might never even use the term trauma. You might just talk about stress and stress reactions and coping with situations that have been very dangerous or very upsetting in the past. But then the shift is always to focus on not just what they should do in order to cope better, or to turn down their alarm, but to actually draw out or provide examples where they have been able to actually catch an alarm reaction on their own, so that the youth then begin to realize that A, they're capable of handling stress reactions, maybe more so than they realize, and B, there are adults in their environment who actually notice that capability and respect it and value it and support them in developing it. So, long-winded answer, but I hope that's a useful way of thinking about that conversation. It's a great one.
Thank you very much. Two of the questioners wondered about the connection that between the youth in the juvenile justice system and their exposure to domestic or partner violence. I think anecdotally and in our gut, we all think that probably the majority of the kids who are in the juvenile justice system have had that kind of exposure to violence. The question seemed to be curious as to whether or not that's been your experience in the studies that you and your colleagues have conducted.
That is also an excellent question, and I would have thought that the majority have experienced domestic violence. It's possible that many more have than feel able or comfortable in disclosing that when we do the screenings that we've been talking about. But using the kind of screening approaches that we're talking about, even with as much emphasis on engagement as I've been talking about, we're finding that it's more like 20 to 25% who acknowledge significant exposure to family violence. Now again, that may be an understatement, but it's also entirely possible that for many of these youth, they've experienced such a range of different kinds of violence and victimization and losses that as important as family violence may be in setting the stage for them to have difficulties with aggressive impulses or aggressive actions or ways of thinking, that may not be so much the trauma focus as it is the kind of social modeling, unfortunately, of actions that are potentially violent or harmful. And in that sense, what we're really trying to do is not assume that youth are necessarily reacting to family violence because they're traumatized, but more that they're reacting to a wide range of different kinds of vulnerabilities and lack of safety and lack of protection in their lives. And domestic violence, unfortunately, may be one of them, but it's far from the only one. And indeed, much of what happens in domestic violence that's detrimental for youth is not just trauma, and sometimes it's not even traumatic. It's just very upsetting and very difficult, but it's the modeling of that kind of way of approaching conflict and stress. And that's where, by helping youth to recognize that the stress issue is to be able to stop and think so that your alarm doesn't control your behavior and your life, if adults are able to stop and think, they're much less likely to engage in aggression or violence. And so that's really actually something that the youth can take back to their families rather than thinking of their families as potentially the source of the problem.
Another very positive comment is the information you shared this afternoon should be mandatory for all those in juvenile justice settings. And they go on to ask, has it been difficult to get the juvenile justice system community to buy into the understanding the importance of knowing about the effects of trauma in the lives of the youth they serve? Has it been a struggle, or have you found by the registration today, I think people are very open to it, but have you found it as a struggle to convince those of us in the juvenile justice system to be mindful of the trauma that the youths have experienced?
It has absolutely, Ned, not been a struggle at all. I have been just completely impressed with the receptiveness, the way in which the people in the juvenile justice system at all levels have been so open to this perspective, and it's just quite remarkable to me when I hear judges or I hear detention staff or probation officers talking about how they've known all along that the youth that they're working with or the youth that they're supervising or adjudicating, that these youth have had terrible things happen in their lives, but they just haven't known what they could do about it. And I've experienced just truly a very inspiring willingness to take this perspective on, because it's not in any way contrary to good juvenile justice practice and to very serious sanctions and mandates and following the laws and the regulations very carefully, because this is really a way in which we can actually ourselves be more effective in catching our own stress reactions, which are often triggered by youth. That's their other job description, is to trigger our alarms as adults. But I'm saying that in jest, but also in some seriousness. By taking a trauma lens, but a lens that is focused on how trauma, the issue in trauma is that what's adaptive in survival becomes maladaptive in ongoing life. And our job is to help kids who are in survival mode gradually feel safe enough and recognize their own capacity to be able to manage their stress reactions in a way that that shows them they don't have to be in survival mode. I found that one quick add-on to that, one of the first administrators who I ever tried to convince that this would be important was somewhat skeptical, and I think there's good reason to think that, because trauma could be used as an excuse. Trauma could be used as a way of not actually following through in a rigorous manner with rehabilitation and with adjudication, and it should never be that. But he was skeptical until he took some of these materials home and left them out on his coffee table at his house, just because he was reading them over, or he wanted to see what's. And his wife the next morning said to him, "You know that stuff that you brought home with you? You need to use that and read that yourself, because that's you too." And she wasn't being critical or insulting. She was just simply pointing out that we're all human beings who have stress reactions. And if we're trauma-informed, we're going to be more effective in how we handle our own stress reactions. And I found that there's been almost 100% buy-in to that. This is not about therapizing. This is not about pointing out any kinds of weaknesses or problems in us or our program. This is all about simply pointing out that we're all in this together. And we all have to deal with stress. Kids who've been traumatized just have to deal with stress to the nth degree.
I'm really glad you mentioned that, because actually I was going to ask you about the staff. The fact that many of the staff are not in touch with their own stress and their own trauma. And in working in a youth correctional facility, and the youth who are there now, I mean, the numbers have gone down, but the youth who are there now present a very complex picture. They're youth with serious mental health problems, youth who have been exposed to trauma, youth who have had gang activity, and so therefore there's an enormous stress on the staff who work in those facilities. We only have about a minute or two. Could you just extend that thought a little more that you were just talking about, of how we need to help the staff to deal with their own trauma before they can really be responsive to the understanding the trauma that the kids are experiencing or have experienced?
You put it perfectly, Ned, and all I can add to that is that what I found to be the best way to help staff at all levels deal with their own stress or potentially their traumatic experiences and traumatic stress reactions is to scale that down so that it's the issue is really, we all have alarms in our brains. We all have stress reactions. And sometimes there will be certain triggers that are individual for each of us based on our life experiences. That may be trauma, it may be something else. But if we are able to recognize our own stress reactions and know that there is nothing wrong with them, that it's not a sign of weakness, it's not a sign of ineffectiveness, it's simply a sign that we are protecting ourselves and our bodies are going to protect ourselves, and we can catch those stress reactions and turn them into an actual way of being highly effective by thinking really clearly. If we do that in terms of our own triggers when we're working with youth, then we bring to the youth the actual demonstration that this can work. And we are, as I said earlier, we're walking the walk along with them. That I've heard many, many staff and judges and administrators and clinicians say that's been so important to them personally, even though they're not going to talk about the personal stuff because that's private and that's the way it should be. But they have used this approach personally so that they would be able to be highly effective under stress, whether it's traumatic stress or work stress or vicarious trauma. So I hope that is kind of a final useful take-home message for all of us. We're all in this together. We've all got stress reactions, and we can all benefit from being trauma-informed because it's really just about learning how to think clearly under stress.
I think it's a very wonderful and uplifting thought to end the webinar on. And Dr. Ford, on behalf of all the CJCA directors and our other members, our affiliate members, our associate members, and all those who participated in today's webinar, I want to sincerely thank you for a very enlightened and uplifting presentation. Thank you so much. Just as a final note to everybody, again, this will be on the CJCA, this webinar and all of our webinars will be downloaded on the CJCA YouTube page. And our next webinar in this series, as I mentioned before, will be by Dr. Chris Branson, and that will be on August 17th. The very fact that you participated in today, you will get a notice of that next webinar, and you'll get a notice of the other webinars. We have a series of webinars that we are conducting on reducing the use of isolation in facilities, and they've been very well attended as well. So on behalf of everybody at CJCA, again, Dr. Ford, thank you so much, and to all those who participated today, thank you very much for spending your time with us this afternoon. Goodbye.
Thank you.